being here in this building that has such a tradition behind it is exciting and humbling. So thank you truly for the invitation. This is a picture that I often use when I talk about toxin. You might think, what does that have to do with it, especially after lunch? Well, the reason is that, as you know, botulinum toxin is responsible for a food poisoning, and interestingly, the very first time that this happened, it was sausages who were responsible. And you may or may not know that in Latin, botulus means sausage. So that's how the name came, all right? So botulinum means sausage derived, all right? Which is fun. And we tend to think that this is a US product because it was first used by the ophthalmologist Scott. Actually, that is not true. There is a contribution from the US, but a lot of the history behind toxin is actually from our old Europe, including the very first time that the food poisoning was discovered, and this happened in Germany. And the guy who realized this was actually a genius, because nearly 200 years ago, he realized that whatever was the cause of that food poisoning in the future, it could have been used pharmacologically, okay? So that was a pretty clever thing that he found out. And then always in Europe, there was a microbiologist at the end of the 19th century who actually identified the little bug that was causing the disease. And then just before 1950, it was in this country that the discovery of the actual mechanism of the product was identified. And then this was, of course, developed further clinically in the USA. So I think we should keep Europe in high spirits and give Europe a lot of the merit for the discovery of the actual drug. And this was the very first application that was licensed by the FDA. This goes back to 2002 for glabella, of course, as you all know. And glabella has been a formidable teaching area, because from glabella, although it seems so simple, we have learned many, many things. First of all, the patent, which is still in the SPC of many, many drugs on the market, is more or less this one. And I can see Andy Pickett laughing. Why are you laughing? Because you know exactly what I'm talking about. Now, the issue is that to change this actual patent, the companies have to go through a very, very long process, legal process and economic process, which takes a long time, and they don't always think it's convenient to do so. But the first recommendation is forget this patent, because this patent will get you into trouble. What happens when you inject so high is that you always have diffusion of the product towards the lower fibers of frontalis, and this will cause dropping of the medial head of the eyebrows, giving you this wonderful result, which is absolutely ghastly. Although in the Middle East, sometimes patients ask exactly for this. But if this is not your cup of tea, the reason is that you're injecting too high and you should drop that. And by the way, in this case, I think the patient also had some degree of upper eyelid ptosis. So this is two damages in the place of one. So the suggested pattern is to keep a lot lower with those injections. And some of you might think that this is more dangerous, that this might get you into trouble with upper eyelid ptosis, which is not true if you do the injections correctly. And doing the injections correctly means simply remembering the three-dimensional orientation of this muscle. The bony origin is very, very medial, and of course, being a bony origin, it's very deep. Whereas as it directs upper laterally, those fibers become more and more superficial, insert into the dermis, more or less at the mid-pupillary level. And so to be safe, you want to inject deep, medially, and very superficially laterally. And if with your thumb you actually elevate the soft tissues, you will have a further degree of safety. That injection has to be done very precisely, because although the effect of a corrugator is extremely powerful, if you think of the movement that it actually generates in the glabella area, it's a very small muscle. So dynamic assessment of the patient will give you clues to where exactly it is, and that's exactly where you want to go with the needle. As I said, the issue in this area is having eyelid ptosis, which is due to unwanted diffusion of the solution to the levator palpebrae. If you do the injections correctly, the risk will never be zero. There's always a little chance of having this kind of complication, but you will actually reduce to probably somewhere 0.5% the chances of this happening. And of course, we have eye drops that can help us if this ever happens. Eye drops that excite Mueller's muscle, and this will help the patient for the time being before spontaneous recovery. Another thing that we have learned is that we have to personalize treatments. The actual pattern in the SPC is for beginners only. We know from Ada de Almeida's paper that glabella can be subdivided into several types, converging arrows, omega, inverted omega, and so on, which means that we can only understand what exactly is the situation of that patient if we ask that patient to express dynamically. And that's the way that an experienced injector should act when he or she decides how to develop the pattern. Another thing that we have learned, and what I'm saying is obvious, but many, many times I see injectors who just do 20 units, boom, 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 in the usual points and forget to look at how powerful those muscles are. And of course, knowing how powerful the muscles are means determining an optimal dose. It means not wasting product when those muscles are not that powerful. And it means not having insufficient results when the muscles are much more powerful than we think. There are difficult patients, and this is one patient that gave me a big disappointment after the first injection. Because if you look at the difference between pre-treatment and post-treatment, there isn't much. That glabella line, which is not a line, it's a true furrow, is more or less still there. And yet, the effect on the muscle was, I would say, full. If I ask that patient to frown, there's hardly any movement there. And you might believe me or not, but if you look carefully at the picture on the right, you will see that the distance between the medial heads of the eyebrows has definitely increased. Therefore, that means that the actual muscles have responded. Why is there no adequate response on the skin? Because that furrow is just simply too deep. And it will change over time with subsequent injections, but after the first one, the result is disappointing. So what happens with that patient? That patient, if she has been told about this beforehand, will accept it, she knows. Otherwise, she will think that we are not good at our job or that we have cheated her. So there's a very simple way to determining when you see very, very deep lines, if that patient will have a good result right from the start or not. And this is the maneuver which is so simple and that can help you so much. In the left hand, on the left-hand side, you see the patient, you see the physician, putting his or her fingers on the forehead of the patient, applying no force at all. In the central picture, you see lateral distraction. You see that we are pulling the eyebrows apart, and yet those furrows do not change very much. And on the right, you see maximum energy in this. Those eyebrows will just not stretch anymore, and yet the furrow is still there. This, you know, is a difficult patient who will not respond adequately after the first injection. What happens is that over time, with repeated injection, the results will actually improve. And what you see on the right is, I believe, after 4 treatments, and you see how very much the situation has changed. These are all things that are present in the literature today, Andy. I think there are many, many papers, incidentally, from every single company, not just one, and they all confirm the progressive improvement over time. So this is something that we should always consider, because this really gives us a hand. And so either the patient accepts the fact that she has to go through several treatments to get the result, or if we want to be really quick, we look for synergism with HA, which works beautifully. So what you see in the middle is the result immediately after toxin. What you see on the right is immediately after HA, which was probably injected only about 2 weeks later. So there is a way of making people happy right from the start, even if they're difficult. The issue is finding out which patient will need this, telling them about it, finding an agreement. Otherwise, it's trouble. There are poor responders. What are poor responders in my language? They are patients such as these 2 that have had a full dose of toxin, and their corrugators are still working very well. And you can see it very well here. So in the previous case, corrugators were knocked out, but you could still see the lines. In this case, the corrugators are still pretty active. Now, why is that? And we're back to the issue of antibodies. Professor Dressler has told us that with aesthetic treatments, yes, we can have antibodies, but the percentages are extremely low. With Botox, it's about 0.3%. With, with Dysport or Azalure, however you want to call it, it's more or less there. And with Mertz's product as well, we are between 0.3 and 1% in the cosmetic use. Now, you realize that this is an extremely low figure. We are talking about patients who've had repeated injections, and interestingly, many of these still respond clinically. So there is a contradiction there. They develop neutralizing antibodies, but they still respond. On the other hand, there are non-responders or patients who become non-responders who are actually antibody negative. And I wish Andy could give us an explanation for this. I have been cheeky at one meeting. I have asked him this question, and he was very honest in saying, I really don't know, but that does happen. So we must be prepared that some of these patients, although antibody negative, just do not respond. And interestingly, after a couple of years or 3 years, they start responding again, and nobody really knows why. We now know that the response to all 3 toxins is extremely quick. Every single company claims that he or she is quicker than the others. And maybe one day we will have evidence, precise chronometric evidence of this. But we are talking about a latency on average between 2 or 3 days, which I think clinically does not really have a lot of importance. And how long do these results last? Well, of course, that depends on the initial dose. It also depends, I think, on the patient. But I think it's pretty honest to say that on average, results will last at least 4 months. On the therapeutic side, the results might not be as long-lasting, but in the aesthetic field, they certainly are. If you look at the patient on the left, look at those brows, they're really low. In the middle, the result is full. There's a nice brow lift there. On the right, we are at 4 months. You see the level of the brows is not there anymore. They are beginning to come down, but there still is an obvious difference between the level at the beginning. I will not talk about long-term safety too long. Professor Dressler has addressed this issue extremely well. We know that patients who have been injected for years in the therapeutic field, so we're talking about sessions of 500, 700, 800 units, maybe 4 times a year, they're doing fine. So you can imagine our patients who on average maybe do 50 units 3 or 4 times a year, or even only 2 or 3, well, the amount of side effects is extremely low. So the information that we have had from glabella has been huge. And of course, this was the first on-label indication, but immediately clinicians starting injecting in the nearabouts, and in particular on frontalis. Now, I don't know your feelings about frontalis muscle. I'm very much afraid of frontalis because I think frontalis is, in my hands, the most difficult muscle to treat. To me, and I'm sure most of you don't agree, but I think that it's good that I can tell you why. So to me, frontalis treatment is a true trade-off. And in Italy, we have a saying that I think is fine, that you cannot have a full bottle and a drunk wife, okay? So what does that mean? It means that whatever we do with frontalis, using low doses, high injection points, low injection points, we will always have something happening at the level of eyebrows in terms of lowering of the position of eyebrows that maybe we are not looking for. And I think you know all about the frontal balance, the elevators being the frontalis muscles and the depressors doing this kind of tug of war. So if we take out one of the players from the elevators, in other words, if we knock out a little bit of energy from frontalis muscles, unavoidably the eyebrows will respond in some way. This, I think, for instance, is a very difficult frontalis to treat because, as you see, the lines are quite deep and they extend right from the hairline down to the brows. And of course, the desire of this patient is only to treat frontalis. So low doses, high injections, hoping that the eyebrows will not lower too much. The result is improved. I'm sure it is, and I think you'll agree. But still, look at that little pinch just about the left eyebrow. The level is not exactly the same. She's happy because she's only focused on the horizontal lines. But again, to me, this is a very difficult treatment. What was this lady treated for on the forehead lines? For no reason at all. They are very, very unconspicuous. She hardly needed this treatment at all. And if you look at brow position, it is definitely lowered after the treatment, and the forehead looks more or less the same. So I think that in doing forehead, we must be very critical. When we do glabella, there's hardly anything to lose. When we do the forehead, we have to be careful. So to make a long story short, I have revised my way of treating the forehead quite a lot over the years. The way I do it now is a little more time consuming, but I like the results so much better. So I do full dosage on glabella. I do normal dose, which would be 20 units. I do normal dose on crow's feet line, or even a little more if I'm doing a brow lift. I will do a very low dose on the forehead. And when I say low dose, I mean 8 to 10 units maximum. Sometimes it's as low as 6, 8 units. And as you heard this morning, there is a very clear correlation between dosage and duration. So I know that by doing such a low dose, I will have half-time duration. And what I do, I tell the patients, I say, listen, at 2.5 months, come back to the office. I will give you a free touch-up. Of course, the free touch-up is calculated in the initial fee because I don't want to make any money out of that, but I don't want to use it. I don't want to lose any either. So what I'm doing, I'm losing maybe 10 or 15 minutes of my time to do that little touch-up. But to me, this has definitely improved the results in the upper third of the face. I do not have any drop in eyebrows. The expression on the forehead is still there because there's a little bit of motion. And by doing this halfway touch-up, the patient is always fine, and she loves it. So it might be just 4 injection points, such as in this case. If there's a higher forehead, I might do 2 parallel lines. But to me, what really counts is doing half dosage. Now, is a drop in the eyebrow always negative? Well, it is in the aesthetic field, But in some cases, it's magic. And this is why, Professor Dressler, I asked you about facial palsy treatment. Because as you see, this patient has a left facial palsy, which is final. I mean, this, when I met her, it was 10 years old. She fell off a horse, crashed her head, and this is the sad result. And the huge deformity is due to the fact that she is trying to compensate on the right side. And this always happens in facial palsies. So by putting gently to sleep the hyperactive muscles on the right side, you will be able to balance the situation so effectively. And if you're even better than that, you can also take care of the synkinesias on the palsy side. And believe me, in some cases, the results are really, truly wonderful. Another tricky thing of frontalis treatment is what we call Mephisto look. Do you understand what I mean by Mephisto? How do you call it in your country? Same way, okay. Now, Mephisto is a complication which looks pretty bad, that to me is only physician dependent, okay? It's not a joke of the drug. It's because of the fact that we inject frontalis muscle medially and not laterally. And when you treat frontalis muscle, and I would say any other muscle, you do not inject just one portion, because if you do, you will have overaction of the healthy or untreated side. And this is exactly what happens in this case. And it looks so badly. I imagine that this patient was only treated medially to those two vertical white lines. Now, predicting Mephisto is not a bad thing to learn, okay? You might say, okay, I don't need to predict it because I treat the whole muscle and I never get it. Okay, but sometimes it's not that easy. So look at this young girl. She's, I think, 30. She comes to the office and she asks for upper third treatment, which is reasonable. She has glabellar lines and she looks like a very standard patient. So you ask her to frown and there is the result. Do you pick up any more information there? No, not at all. But then you ask her to contract her frontalis muscles, to look surprised and look at the shape. So there you get a clue. And now you want to find out what happens if you knock out only the medial part of her frontalis muscles. So you apply your thumb to the central part of the forehead, and again, you ask her to elevate as much as she can. And look, there you are. That's a classical Mephisto. So this way, you can actually spot those patients that are at higher risk. This way, you can determine exactly the point where you will put those 0.5 to 1 units in order to prevent this. And this is a very nice little trick to learn. Thank goodness Mephisto can be corrected in just a second. It's one injection in the highest point. So this is exactly what happens. On the left, you see the Mephisto. In the middle, you see the point where the unit will be injected. And in 3 or 4 days maximum, the deformity is actually corrected. One thing that I have learned is to tell patients always, listen, Mephisto is this. You will never get that. But if ever that happens, call the office and come back. And you know what? I do that every single time now, because one patient one day came to me and she said, listen, doctor, you know, last time I had a funny result. I had my eyebrow with a huge peak up there, and it didn't really look good. And I thought, oh my God, this lady has been around town for 4 months. So you can imagine what a bad advertisement that is for you. So funnily, sometimes patients come back complaining and they have an excellent result, and you don't know why they are asking for a touch-up. Otherwise, sometimes they do have a problem and they just don't come back to the office because they're shy, they don't want to disturb you, they don't have time. I think it's important to tell them if something goes. I don't encourage people coming back from touch-ups because you lose a lot of time. But sometimes if there is a true problem, it's very important to take care of it. Okay, this is a category of patients that surgeons would spot immediately. Aesthetic doctors and dermatologists, not as much. You have patients coming in with very deep forehead lines and very high eyebrows. These are two of them, okay? A surgeon would immediately recognize eyelid ptosis. On the left, it's monolateral. On the right, it's a little more difficult to spot because it's bilateral. And these are two very serious cases. Now, what goes on here? The impossibility to elevate the eyebrow adequately reduces the visual field. The brain records this, doesn't like it, and so tries to compensate this with frontalis muscles. And this is why those eyebrows go sky high. This is why frontalis muscles are so powerfully contracted. If you give toxin to these patients to treat the lines, because this is why they came in, I want you to treat my forehead lines. And if you carry on and do that, you will knock out the physiological compensation, and they will have an even more serious ptosis. So these patients should be sent to the surgeon. All right, you might say, these are not very frequent cases, but this is a frequent case. This is a 70-year-old lady who cares about her looks and has very high eyebrows and horizontal forehead lines. Look at the hooding of the upper eyelids. This is another patient who should not be treated with toxin for the same exact reason, because otherwise frontalis muscles will not be able to elevate and the patient will not have her physiological compensation. This is a patient who should be operated of a very simple thing, which is upper bleph. And as you can see on the right, after the operation, the eyebrows have dropped to a normal level, and she's okay. And on the forehead, those lines are just not there anymore. So let me read this because I don't remember it. My conclusion: when at all possible, I don't treat the forehead. I know you'll all disagree, but that is what I think, of course, except in selected cases. If eyelid obstruction is there, of course, I would not. When I do treat the forehead, and I have to often because this is what patients are looking for, 8 to 10 units in total, high and subdermally, and I do treat them again for free halfway through the duration of the treatment. And I, of course, distribute medially and laterally the injection points. What has this slide got to do with it? These are my favorite patients because they have a fringe, you do not see the horizontal lines, and they keep me out of trouble. So I love this kind of situation, okay? Now let's move to crow's feet lines. Crow's feet lines, I don't mind crow's feet lines when they are moderate because I think they make you look happy. They are the lines of smiling and of laughing. So I don't see them with the same negative feeling that I see glabella lines. However, in many cases, patients want these, and in one case in particular, they are very useful to treat. This is the standard treatment, not much to comment. 3 points, 4 points, depends how much they extend. You can direct the needle laterally, which is even safer. We have become more and more superficial with these injections. We can do this, especially at the crow's feet line level, because there's hardly any fat interposed between the skin and the muscle. And if we do not reach the muscle with the tip of the needle, we have a lesser chance of having an ecchymosis. These are tricky patients when the extension of those lines goes down towards the cheek, such as in this case. And I recommend to keep away from those lower lines because otherwise you can interfere with the zygomaticus major, which you see right there. When you have those lines that go very clearly downwards, they are produced by contraction of orbicularis, but by the synergy of zygomaticus, and you don't want to get that in your way. Otherwise, you will have an asymmetry of the smile. Where treatment of crow's feet lines to me is precious is when I want a brow lift, which is almost every single time in females. This would be the pattern. As you see, it's not only the lateral injections in the orbicularis, it's also the upper lateral part of the orbicularis. If I want to maximize the brow lift, I try to keep away of the forehead. And in many, many cases, I think the result is wonderful when those eyebrows are low. Elevating the brows is so precious. And in and in many cases, to maximize the elevation, you can use a little bit of fat or a little bit of HA in the upper lateral part. And again, as we said for glabella, over time, the result will improve more and more and more. So I think this is another thing that we can promise to our patients. Bunny lines, I don't think there's much to say about them. In some cases, they are deep and they do deserve treatment, but this is unusual. Other times, they are a telltale sign of the standard upper third treatment, and sometimes people spot them, so it might be a good idea to treatment when you run into them. Gummy smile I love doing because I think the results are absolutely spectacular. Unfortunately, I have very few patients who ask for that. I don't know why. Every time I see one, I would treat them for free because I think it's such an amazing application. Look at that. I think this can change your life. It's not a difficult treatment to do in terms of localizing the muscles. It's very important to keep the doses down and to do it in 2 separate sessions. A first session, which is usually more than enough, is actually the injection of levator labii superioris aliquae nasi, which is the most medial of the upper lip elevators. Checking the patients at 2 weeks, no more than 3 units per side. And then if the result is fine, this is the landmark of the first injection, just above the nostril at the angle between the maxillary bone and the nasal bone. It's a deep injection. And then checking the patients at 3 weeks. Don't do this in patients who have very long upper lips because it will lengthen the upper lip. And as I said, a second injection, just a little more laterally in case the result was not good enough. You then move laterally to the levator labii superioris. Barcode is another difficult treatment. I do not think that you can actually manage barcode adequately with toxin only. I think it's more a matter of synergy with HA. But anyway, technically, you have to inject very, very superficially, very, very small doses. As I said, with toxin only, you do get an improvement, but it's never dramatic. Whereas with the help of HA, you can actually get pretty good results. So what you see in the top middle is toxin only. You see that the barcode has improved. On the right, you see that with the help of HA, you get an even better result. And in the lower picture, those horizontal arrows simply mean that I do not inject into the actual lines of the barcode, but I try to make a very, very thin layer subdermally on the whole white skin, under the skin of the white lip, in order for the product to lift and stretch those lines, okay? And this is something that I've been doing lately, which I think works quite well. It would deserve a longer talk, and that is mixing HA with toxin in very clear proportions and doing that layer, subdermal layer, with both, okay? So what happens is that you have the mechanical effect of the HA, and I believe what might be a slow release of toxin. I don't know if that is the reason why it works, but the results are quite nice. Actually, they're very nice, and they're long-lasting, okay?
Can I ask what dose of Botox you would mix with a mil of filler?
That is a secret, but I will, but I will share it, of course. So that The rationale is that when I use toxin only in the upper lip, I would use 4 units total maximum, okay? 4 points of 1 unit maximum. And on average, when I do that layer of HA, I would use from 0.3 to 0.4 ml of HA, okay? So the mixture will be 0.4 ml of HA with 4 units of toxin. And when I do that, I don't want to change the rheological properties of the HA too much, so I will use a very highly concentrated solution of toxin in order to have more or less the same fluidity of the HA. Try it because it works very, very, very nicely, and it works very nicely in crow's feet lines as well, okay? So, as I said, a marvelous application to me. Sufi, how much time? Still half an hour? Oh, okay. Okay, because I'm racing, but maybe we can make it. Okay, so to me, a wonderful application, a truly wonderful application is the chin. Okay, I love doing chins. It's not only when you see an obviously contracted chin with, you know, that golf ball appearance, and in many other times you have chins that have a reasonable contraction of mentalis muscles. They don't have a true deformity, but they don't have that forward projection that you would like to see. Okay, so many, many times chin treatment is a very nice complement to the treatment that you do in general. The tricky part here is the anatomy, because in what I used to do, a single midline injection in some cases, but in most cases where I would think that the chin was a little bit wider, I would do 2 symmetrical injections paramedian, okay? And then I got a couple of times I hit the depressor labii inferioris, getting, of course, that nasty deformity, which you will see in a second. So this is the typical result. You see a golf ball chin on the left, and you see how much smoother she looks after the treatment. This is another typical example, but as I said, the danger, where is it? There it is. Okay, this is the danger, okay, getting depressor labii inferioris, which you really want to avoid. So I still think that in large chins you need 2 injections, paramedian, but I do them much, much closer than I used to. So I usually do 2 points that are between 0.5 millimeters and 1 centimeter apart, one from the other, okay?
I'm so sorry, I'm enjoying your presentation, then I got my timings wrong. 10 minutes.
10 minutes. I thought so. Okay. Hyperactive DAO. Okay, this is the sad mouth situation. And again, I thought once upon a time that this was a good idea and that this would help quite a bit in correcting the horrible marionette line. Until I realized that it was not at all difficult to get small asymmetries in the smile. And I realized that the marionette line is actually due to other factors in which DAO can have a contribution, but a very minor one. It's much more a matter of a ligament being there, about descent of soft tissues from above. So I have actually stopped injecting DAO as a single treatment, okay? I still do it in this situation, hyperactive DAO and mentalis. Patients who require this are not many, but when you do spot these, again, the results are quite dramatic. These would be the injection points, 2 points for the DAO and 2 points for mentalis, and this is the typical situation. You see the expression of the lady on the left without any treatment, and you see her on the right. Look at her in 3/4. Look at the shape of the chin. Look at the position of the mouth corners. look at how much the situation has changed. And what is very important is the fact that from a functional point of view, everything is working perfectly. So here, it's really a change of expression that does not at all damage the function of the patient. This is the big thing in the Far East. I was there a few months ago, and I was very embarrassed because all the questions that were being asked were on masseters, and in my country we do very little. Because as you know, in the Far East, hypertrophic masseters are a racial feature and they hate it. In my country, hypertrophic masseters, yes, we do see them, but they're no big deal. And by the way, I'm sure that you are familiar with Angelina Jolie's face. I think many of you think that she's wildly beautiful, but she has the strongest masseters that you could ever meet. So does she really need that treatment to look more elegant? I don't know. That, you know, aesthetics is so subjective. Anyway, this is one of the big things coming up. You have to become familiar with it. According to the size, the extension of the masseter, you might want to do 3 points or 4 or even 5. What is very important is that you get the right needle, because when you are injecting a truly hypertrophic masseter, you have to go all the way down to the mandible, and you have to inject the full thickness of the muscle. So the traditional 12 millimeter needle is not, half-inch needle is not really enough. There are great needles that are an inch long on the market, and they help you a lot. And of course, the results can be very nice in certain situations. There is a complication. There are 2 complications with this treatment. First of all, when you inject very anteriorly, close to the anterior margin of the masseter, you're very near to the insertion of risorius. So you might interfere with the smile. Remember, keep a few millimeters backwards from the anterior margin of risorius. And the other issue with this type of injection is that if you don't get the full thickness of the muscle, but only the most superficial parts, you might run into a very ugly complication that I will show you right there. You look at the patient on the left. This is her after her treatment. She looks perfectly normal, but as soon as she clenches her teeth, she has that horrible lump coming out, which is the deep part of the muscle, which is still able to contract and does not have the superficial part of the muscle keeping it inside. So you want to really make sure that you're hitting the whole muscle. The neck, some applications, but they are rising. They are rising. Okay, so typically platysma bands. So you will inject these points at maybe 1 centimeter one from the other. The critical part of this application is that you want to be virtually intradermal. Okay, there's hardly any fat between the dermis and the actual platysma muscle. And if you go through platysma, which is paper thin, you get diffusion to the deeper muscles of the neck, and there you're really in trouble. So you should do these injections without thinking to get into the muscle, exactly as you would do technically at the crow's feet lines level. You get into the dermis and you wait for spontaneous diffusion to the muscle underneath. This is the very important thing. And don't use too many units. I would suggest 2 units maximum for every one of those points, and then just wait for the result. And if required, you can touch it up. This is a patient that also has been treated on platysma, not for the platysma bands. She does not have any at all. She has had a double line of injections just above the mandibular level and just below the mandibular level. This is a technique that Philippe Lévy from Switzerland introduced about 10 years ago. He called it the Nefertiti lift, which was a great name. What is the whole idea here? Well, in the upper part of platysma, the action of the muscle is actually a depressor of the soft tissues of the face. In the lower part, platysma is actually an elevator of the soft tissues of the chest. Okay, so what we're interested in is the fact that it actually pulls down the soft tissues of the face, and by giving toxin at this level, we downgrade its action. And we rely on the fact that zygomatical muscles will elevate. The difference is subtle, but look at the line of the mandible, which is definitely cleaner. There is some elevation at the mid-third. Possibly the nicest part of the result is the chin, but this, of course, is mentalis. And indeed, when I do this technique, I always combine mentalis because I think the two things work very nicely. This is a particular patient I know very well. He's my nephew, and he has a terrible tic ever since he was a teenager. He contracts like a crazy guy his platysma continuously. He always goes. And ever since I started giving him toxin, it's changed his life, okay? So look at the power of those muscles and look at how you downgrade them. And every time he gets the stuff, he's an addict by now. I always tell him, you're toxic. But for him, it really changes his life. So the theme of tics is something that I do not take care of. It's something that neurologists take care of, but I think they are the best witnesses on how these are important for the quality of life of the patients, okay? Botulinum toxin and the skin, cut. Finished? Okay.
I don't want to.
No, invite me next year. We can go on with that, okay?
Next month. Thank you very much.
Thanks you.